Thanks.
Yeah, so like I said, this was quite an interesting case that I found while going through our M&M, so I just wanted to cover it with the guys. So this would be something that we're all quite used to seeing in the last year and a half. A 66-year-old female patient, 2-day history of respiratory symptoms, all right? Now with saturations of 77% on room air. So we already know what we're thinking about, right? We're already thinking about a COVID pneumonia more than anything else. Okay, especially with how it's been over the last year and something. So respiratory rate of 45 breaths per minute, quite high. Heart rate of 112, again, tachycardic. BP is low, 87/42. I mean, that's now quite unusual for somebody who's 66 years old. It could be due to insensible losses from the breathing and things like that. But, you know, I mean, 87/42, I mean, that's already a mean of about, what, 50? No, just over 60. So, you know, you do have to get worried. HGT is a little bit high, 13.7. This is the worrying part. She was quite pyrexia. So temperature of 39.8. Okay. So I don't know about you, Ricardo, but at the moment, I'm already worried about one thing with the low BP and the high temperature.
Low BP.
And the high temperatures. What are you thinking about already?
So this patient, when fever, could be an infection. We need to check.
Definitely.
And heart rate is high.
Heart rate
could be
high.
Due to the temperature. Sometimes the temperature when it's high could provoke that. Yes.
Yeah.
And high rate, respiratory rate is 45.
45. Yeah, it's 45. So she's severely tachypneic as well, struggling to get in. Sats of 77. Yeah. Surprisingly, the sugar's gone up, but it's not that high, you know. But I mean, with this low BP, high temperature, signs of infection or sepsis, I mean,
it could be a septic shock.
Yeah, excellent. So, I mean, the first thing that comes into our mind is septic shock, you know. So we've got to start treating this patient as a septic shock, you know. So we'll go through what actually happened with the patient, all right? Now, keep in mind that we don't know anything else about the patient, but just looking at the vitals, you should already be thinking, okay, this is septic shock, and I need to be treating this as a septic shock. And I mean, if a patient comes in hypovolemic shock, cardiogenic shock, neurogenic shock, you don't go outside, have a cigarette and come back. You know, you sit with this patient. So this is what should have happened with this patient as well, all right? But we'll go through what happened, all right? So the patient was noted to be a diabetic, all right, but only on metformin. And she had previous history of a polycystectomy and 3 C-sections, all right? So we all know diabetics, hypertensives, and those are with the combination are the highest in terms of mortality, right? In terms of COVID, right? That's always been the case.
Yes.
Clinical examination, they say main finding of bronchial breathing in the right lung. Now, the thing is with COVID, you don't generally find bronchial breathing per se. There's sometimes crackles. There's occasionally maybe a bit of bronchial breathing, but then it's maybe quite advanced, things like that. But on the whole, because it's a viral pneumonia, the lungs actually don't sound that bad when you listen to them, you know? They just sound like a bit of crackling and a little bit of creps occasionally, and that's about it, you know? This patient was swabbed for COVID-19, referred for an X-ray, baseline bloods were taken, and then was admitted to the POI wards after the rapid came back negative, all right? Even though everything else was pointing towards it. And we all know the rapid has a high rate of false negatives, you know? So that means there's a lot of patients that are positive, but we get the negative result back. So we have to treat as clinically, all right? Even if we get a rapid that's negative, you know, even though the quality of the rapids has improved, but the overall false negative rate is still quite high. And apparently her SATs improved to 82%, but this was on double oxygen, all right? So that means she had a face mask plus nasal oxygen, and she still only got up to 82%. So Ricardo, even before we move on, you've got a patient in septic shock who is clinically quite suspicious of COVID, who's 66 years old, so not that old, and SATs that are not improving despite high flow O2. Where do you think this patient should be sitting? Where should this patient be going to, in your mind?
ICU?
ICU, definitely. That's where this patient should be going. Instead, this patient ended up in the POI ward, all right? She was just admitted directly there, all right? So she demised 4 hours after admission, all right? So I mean, it's understandable, you know, that she demised because she needed CPAP, BiPAP, or even full ventilation in order to survive, you know. So the sad part that what we found when we went through this, that there was no notes between admission and death, right, except for the certification.
Oof.
Now this is a bad stain on those who are working in the POI ward, because what it means is a severely ill patient was admitted. Nobody saw the patient. Somebody could have even made the decision if A&E was wrong to say, okay, let's take this patient to an ICU. But it just shows that there's maybe a bit of you know, lack of sympathy or maybe fatigue too. You know, that everybody's just fatigued, so that, you know, there's no real care anymore for patients. You know, because this just happened now in July during the third wave. You know, the other thing we noted was that there were no notes in the OP file. So in other words, there was nothing from a medical legal point of view to protect the A&E, and there was only an admission case sheet, you know, in which the admitting doctor from the A&E wrote, and I mean that's unacceptable, you know. As boring as it is, or as tedious as it is to write it out twice, sometimes we have to, because it's to protect ourselves, you know. I mean, if this family did take us to court or anything like that, you'd have no foot to stand on, you know. That's the thing. So
exactly.
Yeah, it's really true, because medical legally, technically, you never saw the patient as an outpatient. You just admitted the patient, and that's it, you know. And there were no emergency orders given. So in other words, the patient was just put in that ward, and that was it. All right. So the admission medications were appropriate. So the patient was put on Clexane, was put on Hydroport, was put on Augmentin, was put on all of those things. But there's no evidence of a fluid resus in a patient who's got BPs of 87/42. So there's nothing.
Yes.
You know, there's nothing to say we're going to give a liter now, monitor the BPs. Are we going to give a colloid as well? Nothing. Everything was just kind of left like that, right? And the other thing was that there was no sliding scale, you know, or continuation.
No sliding scale for
Yeah, and I mean, if you've got a diabetic patient, you have to have a sliding scale to make sure that you know, that sugars are kept under control. And there was no mention of discussion with any department. Now that was a terrible thing from our side, considering this patient may have warranted ICU. So it almost looks as though the doctor was involved in this, just kind of got the patient, did the basics, and pushed the patient off to the ward and moved on to the next patient. And even if that wasn't the case, but that's what it looks like on paper, and it's a horrible thing.
They put her in the box of COVID.
Yes, like basically.
If it was COVID, done.
It's COVID. You just go to the ward, and whatever happens to you, so be it. You know, that's the thing. So our learning points from this one was a patient was in septic shock. Now, I mean, this year we've covered septic shock so many times, you know, so I'm not going to rehash the whole thing. But the thing was just to, you know, to impress on everybody that COVID-19 patients do experience septic shock. It's quite common amongst them. Even though septic shock is more common amongst bacterial infections, but with severe viral infections, it's been known to happen as well because of the release of cytokines. And they also have a vasodilatory effect, you know. So how do we treat septic shock? We, like any shock, you know, except for cardiogenic shock, we treat with fluids, you know. She should have been treated with fluids. She needed to have colloids, you know, she may have benefited from colloids. We don't know what her baseline UNE was, but she would have benefited from colloids. I've taught you guys how to do the IVC compression ratio, the ultrasound, and we could have looked at that as well to see how much of fluid she needed, so that we don't you know, overload and things like that. And of course, with these patients, you need to monitor input and output, you know, so urine, best indicator of success, you know. I mean, there's new things in, you know, the survival of septic shock guidelines, and that, you know, you know, the administration of calcium and the administration of vitamin B and things like that. But because it's not part of the overall guidelines, it's fine, you know, you don't have to do all of that, you know. But just even if you start antibiotics, you start antipyretics, you start, even in her case, cortisone would have helped, you know, because hydrocort is a beta-2 receptor agonist, you know, it would have helped, you know, and it would have helped to even
at least 100 milligrams.
Yes, at least, you know, and it would have, you know, helped with some of the inflammation in the lungs at least, you know. And you know, if a patient doesn't respond, then you go to inotropes or vasopressors and things like that. You know? Right. And then diabetic control is best achieved with a sliding scale in the case of infection, because once they've got an infection, their blood sugars are just going to go all over the place, you know, just keep on going up, sometimes drop, things like that, you know. So this patient, as you had said from the start, this patient was a candidate for COVID ICU. All right. So the times that we think about is when we're unable to get saturation above 94, despite large amounts of O2, not necessarily high flow like BiPAP and CPAP or Enoxera, but just the fact that we can't get them above this with baseline oxygen is a bit of a problem, you know. So this patient, we've got CPAP, BiPAP at our facility. I know you all don't have it yours, but we have these facilities. You know, it's just a question of the patient going to the right of the passage or the left of the passage, and then it could have, and the patient could have survived, you know. And then we have medical officers from internal medicine. They've all been trained, you know, to manage these patients. So basically what I'm saying is sometimes you have to use the resources available to you, you know. So if you suspect something is wrong, ask, you know, even if you're not sure, you know, you've got to at least try, you know, and do something. So what we all suffering from COVID fatigue, and with the fourth wave coming, going to be even more fatigue, you know. It's very tempting to say, it's a COVID patient, just go, you know, and whatever happens to you, happens to you. It's similar to what happened to HIV patients in the early days, you know, where you were HIV, it didn't matter what else you had. You know, you could have had a gunshot abdomen, but you had HIV, you were in the HIV ward, you know. That's how it used to be, you know, and we can't do that to the COVID patients as well, you know. It's not what we train for. We train to save lives, and we can, you know. So, and in this case, in this patient, ECG wasn't done, ABG was not done. Those two should have been done. And then temperature control, you know, we can do temperature control, simple analgesics, Panado, you know. And NSAIDs, we have access to Brufen, we have access to Voltaren injection. These can all help to drop temperature as well, you know, which can also assist these patients. So unfortunately, this poor lady,
blood gas, I think the blood gas wasn't done, no?
Yeah, the blood gas wasn't done, so we can't comment. We don't know what a blood gas would have looked like. I'm sure it wouldn't have looked good. I mean, we would have had a severe lactic acidosis, you know, and things like that. We may have been able to pinpoint early urinary problems, things like that, you know, renal impairments, things like that. But because it wasn't done, there's no way to know, you know. So, and the ECG not being done also, you know, deprived us of a lot of information that we could have actually picked out from there. But it was never done, so we can't comment. You know, we don't know what would have happened. So like I said, this poor lady, she died horribly. She died alone, and she didn't need to, you know. So these were just some things that I wanted to point out. So, I mean, I'm sure you've been seeing this as well quite a bit, you know. So these are the typical X-ray findings, you know, that we find in COVID-19 pneumonia. You know? So what happens is initially you start getting these patchy infiltrates, you know, that start to spread out from the hilar region and go from there, you know. And then, as they say, you get this reticular interstitial pattern, which is, I mean, reticular, you know, passing out in that manner, you know, where it's just like reticles that are coming out. You know? And it's mainly peripheral. That's the thing, you know, as compared to a pneumonia, which tends to be lobar, or bronchopneumonia, which is patchy but quite consolidated. This tends to be that reticular type pattern that's starting at the periphery, you know. So let's follow this patient. You know? So this same patient now from A, who was developing signs, now has a chest X-ray taken 3 days later. All right. So now she's positive. All right.
She's getting worse.
Yeah, she's getting worse. You know, so you can see the peripheral alveolar opacity. So in other words, now we see the periphery starting to get worse. You know, we see the periphery starting to get worse, and then you know, that's what tells you that this is not doing too well. Let's have a look at another patient. So this was a 57-year-old with dyspnea, positive PCR. So we can see the bilateral opacities, all right, in the upper, middle, and lower field. All right. So in other words, we can already see the peripheral infiltrates. And with the majority of our patients, this is actually the X-ray sign that we look for, which is a peripheral reticular type of pattern, you know, and you see it. You don't need to be a radiologist to pick this out because it looks so different from anything else that we see.
Yes.
We don't see it on anything
So maybe you don't know what is happening inside, but you have to know that it's wrong.
Yes, exactly. That's for sure. You have to know. And you have to be very suspicious of COVID when you see that. That's the thing. And let's have a look at another one. So the D was a 45-year-old male with dyspnea and COVID-19 confirmed. AP chest X-ray showing multiple bilateral diffuse confluent areas of consolidation with extensive involvement of both lungs. Note the presence of two. Well, all right, he's got his 2 CVPs in the right subclavian, but this is advanced COVID. You know, this was a patient now who needs to go into ICU. You know, that's the thing. But we'll
severe one.
This is a severe one. You know, you can see now it's spread from the peripheries. It's starting to affect the bigger airways, and that's why it gets. But I mean, this typical pattern that we see of this peripheral infiltrate, reticular type infiltrate. I mean, that's what we see, and that's what we need to look out for. I mean, all of us should know this, just like how we used to know TB, you know, how we know a TB X-ray, we need to know COVID X-ray these days. So this is just a simplified sliding scale, you know, that a lot of people can use. I mean, there's so many sliding scales out there, and some of them are quite technical, and they take a lot into account. And the majority of the time, it's no use starting them on a very technical or, you know, a highly modified sliding scale, because you, and when I say that, I mean from the emergency department point of view, because you often don't have all the information. And then as the patient is worked up more, that's when you get more and more information, you know. So, you know, hopefully, you know, people will just take a screenshot of this if they need to, and then keep it on their phones. And I mean, it's quite easy, you know. Basically, the higher your sugar, the higher your act rapid, and you know, the higher your sugars, just make sure that one of the doctors are involved, you know. And you get down to this point where eventually you don't need any. And once the patient is now dropping, then you start giving them a bit of glucose. And just, you know, the one thing I often saw on our strips, I don't know about you guys there, you might have seen it as well. You'll have patients diabetic, but you know, severe CCF and all of that, and they'll have a similar 1 liter, 5% glucose over 4 hours or 6 hours, and they're dead the next morning, you know. So especially overloaded patients, yeah, you know, just keep that in mind, you know, just don't give them too much, you know. And the thing is, once they reach this point, they need to have their HTTs checked at least hourly, you know, just to make sure that everything's all right. And of course, once they become hypoglycemic, you know, we go through the normal 40 mils, 50% dextrose. You have to have the doctor involved immediately and things like that. You know? Yeah. So yeah, that was the end of it. I hope you learned something as well, Ricardo, because I know you're very involved in it. You also see it, and you know, we've both been dealing with this now for a long time. It does get tiring to actually deal with it, but you know, from an ethical point of view, from a personal point of view, and from a clinical point of view, we have to give these patients the best that we can, and we hope that they, you know, that there's a good chance of survival. You know, I mean, the reason why Amajuba is in so much of trouble is because, I mean, we had a 23% death rate for a disease that has a global rate of 2%, you know. So that means 1 in every 4 patients that are walking into our wards, regardless of which hospital, you know, 1 in 4 is dying, you know, and that's why people are afraid to come to the hospital early. And then we complain that they're presenting late. They're presenting late because we're killing every 25%. All right, Ricardo, listen, thanks so much for joining. And
thanks you.
Sending off the CPD certificates a bit later, and then we'll have another talk next week. Okay.
Yes. So the meetings are in the Thursday and Friday.
Well, Thursday and Friday if we need to do extra ones. Next week, I think we're going to have it on Wednesday because I'm going on leave on Thursday. But I'll let you guys know on the group. I'll post it up. Yeah. Okay.
Thank you.
Okay, Ricardo. Keep well. Enjoy your day.
Right. You too, sir.
Okay. Bye. Bye.